Okay, got it. Okay, folks, as I said, welcome to this public meeting of the HIV Medication Access Workgroup. I am Manny Santiago, use any pronouns, and I am the director of the Washington State LGBTQ Commission. We always at the Commission like starting our meetings with an acknowledgement that we are on indigenous lands, regardless of where we are in Washington or outside of Washington. Some of us are outside of Washington. I myself am not of indigenous descent, so I want to recognize that. And I live in the ancient lands of the Puyallup people. And as part of our beginning of procedures, I wanted to share with you our the Commission's land acknowledgement and recognize that each one of us comes from a different, or is located in a different ancestral lands of indigenous folks. So keep in mind who the people are that inhabited your lands, or the lands that you occupy now from time immemorial. And let me share with you our land acknowledgement. The Washington State LGBTQ Commission recognizes that we live and work in stolen lands. These lands, water, mountains, skies, and everything within them have been inhabited since time immemorial by the descendants of the 29 federally recognized tribes, as well as the many not recognized tribal communities in the state of Washington. We recognize the history of colonization, genocide, subjugation, and enslavement experienced by indigenous peoples in these lands and throughout the continent. It is our commitment as a state agency to recognize tribal sovereignty, to work alongside tribal partners for the well-being of our communities, to celebrate the achievements of the many indigenous communities among us, and to dismantle the ongoing legacy of settled colonialism, as well as the exclusion and erasure of indigenous peoples that continues today. It may be so. And friends, I mentioned the last time that Omar Santana, who had been the program manager for the commission, was moving on to the DOH actually now, and he's doing DEI work, diversity, equity, and inclusion work there. So we welcome Tracy Carlos, who is our new program manager, and she will be your point contact for anything related to this work. So Tracy, do you want to introduce yourself? You have a few minutes or a few seconds to introduce yourself, and then we'll go into some housekeeping.
Sure. Good morning. As Manny mentioned, my name is Tracy Carlos, and I use she, her pronouns, and I'm the program manager to the commission, and I started on Monday, so have a little patience. Welcome to the LGBTQ Commission Virtual Medicine Access Work Group. As Manny mentioned, the chat is for tech issues. Reach out to me if you have any of those, but also please remember that anything in there, even private chat to other people, is publicly disclosable. So be aware of that. And please do not use chat for anything other than tech issues. In order to foster a healthy and safe interaction, if there's any disruptive behavior, the participant in question will be notified by me or Manny about their behavior. If they refuse to comply with safe health and safe interaction guidelines, they will be banned from participating. Healthy and safe interactions include assume positive intent on the part of the commissioners, moderators, participants, and staff. Do not use transphobic, homophobic, lesbian-phobic, biphobic language, misogynist, xenophobic, racist, anti-Black, ableist, ageist, or foul language during your interaction. Focus your comments on policy matters, and name calling or insults are not allowed. And that's our housekeeping, and back over to Manny.
Thank you so much, Tracy, and Martha, it's all yours.
Welcome. And for those of you who've just arrived, I see some new names and faces. We won't have time to go through and introduce all of ourselves to each other as we did at the first meeting. So if you could put your affiliation in your name by clicking on the 3 right dots on the top of your photo, your video, that would be helpful to us all, so we can have a place, if you will, to go with your name. Manny, I wonder if we could begin with what we've been able to take in a bit in the last, since our last meeting. And then I'll do my bit on that.
Sure thing. So as you all know, well, many of you who have participated of this or who have followed the website with updating information, you know that we started with recognizing some facts, some facts and conundrums and issues, things that we as facilitating team have heard from different partners who are part of this work. Now, things have obviously evolved and progressed. And this morning when we were talking, I was sharing with the facilitating team that honestly, we don't have a whole lot that we need to continue sharing because things are moving forward. So there's one observation that I wanted to share with you, one new observation that is important for us to keep in mind, especially those of us who are a little bit more impatient, like I was last week as we were talking, the facilitating team and myself were talking, and I was a little bit impatient with the pace. But I do have something that I want to share with you about what we have seen so far. And that one great thing is that we are seeing some commonalities on issues that need to be addressed and commonality on ideas on how to address those issues. And I think that that's a really good move and a really good step forward. When we started, everybody had a different perspective and a different way of speaking about this, of addressing these. Everybody seemed to have a different understanding of how the issues needed to be addressed. And as we have compiled different perspectives and different conversations and different information, we are seeing some threads that help us identify some commonalities. We will talk about the specifics of those commonalities later, and we have actually a whole section for that. But I want to share with you that observation because I think that it speaks to the hard labor that this group has put together. Even from different perspectives, we are seeing some commonalities and some good common ideas on how to address those issues. Martha, back to you.
Okay, thank you. Tracy, I wonder if you could bring up the agenda. We're going to walk through the agenda quickly, so we have a very full agenda and not much time. And she's going to share her screen there. By the way, while you're doing that, I just have to say, Tracy, you've done an amazing job of just stepping right into a deep pit. Thank you for that. That we can swim out of. So great for helping us do that. For those of you who've had a chance to look at the agenda, please know that what's been posted is going to be different. That's the name of the game with these dynamic processes. I'm going to tell you, first I want to tell you why it's going to be different. We had a flurry of activity, quite literally at the end of the week, where people were like, oh, wow, this is the penultimate meeting. There's just one more after this one. Let's really get in there and pay attention, which is great. But for those of us who were hoping to take the weekend off, well, some of us did anyway. The agenda is there's going to be some stuff happening real time, and we're going to be working with it. In particular, here's one of the things that happened. We had asked those of you who've been participating so far to take a look at the draft report, which if you've had a chance to look at it, you'll see it's watermarked that says in process, draft. Please, don't cite or quote because it's still a work in progress. And we'd had asked for your feedback by midnight on Wednesday night. And the next morning we got together all anxious to see what was going to be in those Google forms that you all will have filled out. And there was zippo, not a thing. So we're like, okay, this is the way of the world right now. People are pretty busy. We need to regroup on this. And that's part of what's reflected in this agenda. We had a hope. I was prepared to write another draft for y'all and for us to take a look at it on at this meeting, and then we would kind of buff it up on the 25th at our final meeting. That's not going to happen. What we're going to do today in the second part of this meeting is get a quick overview from you of that report. We're going to do it in breakout rooms. You'll only have a chance to go to one breakout room. And then we haven't confirmed this yet, but my hope is that we can reopen up that Google form for y'all, and then we'll redo the draft again after the town hall meeting on October 12th. So we'll have another chance to get more feedback, but what that means is you may not be able to put the spit and polish on it on the 25th. However, Manny is required basically by the budget proviso to send something to his commission, who will then send something on to the legislature by the 1st of November. So whatever we do will be done shortly after October 25th. And the other thing, if we look at so that's basically skipped to the back end of the agenda. Tracy, would you mind bringing up the second page? So we've just done this. Prior, I'm going to walk backwards from the agenda. It says we'll have 25 minutes for wrap up, but if any of you can do math, as I clearly cannot, we actually only have 10 minutes for a wrap up, but we may do that in less amount of time because I think we're going to need we may need more than 50 minutes for our review of the report in our small group work. It's going to be tight, but we can do it. We also, prior to that, again, we're working backwards here. Renee will give us a summary of the town hall from September 20th, talk with you a little bit about the one coming up on the 12th, and ask for your feedback as well. We hope to take a break. I may ask you to just take your own breaks if we are finding we're really on a roll and we want to stay together. Tracy, how about that first page as we're working backwards? So the other thing that happened at the end of the week is there was really quite a bit of interest in this notion of requested information. And so we're going to have, I hope, a little more time with this. We have several guests who will be offering some presentations, and we're going to focus on these things. The first bullet item is, what does the research tell us about compliance? Is it different for people on multiple regimens? You can read it. I don't have to read it to you. We have Jonathan is going to give a presentation on research he's aware of, and then Carrie has kindly gathered up, Carrie Comer has kindly gathered up a number of insightful and people with good experience who will also give us some information. The second bullet, what does the research tell us about the impact of advertising on drug choice? We will not be talking about that. And I might just put it out there, to use that old metaphor, this is an elephant in the room. There's interest throughout the work group in understanding the role of pharma in drug pricing and for many people, the frustration of the invisibility of how drug companies price, given the reality of our for-profit healthcare system, mostly with, of course, with sidebars and parameters around it, and our system of confidentiality. So there's quite a bit of interest in that, but we're not going to talk about it today. And I dare say that if you've had a chance to take a look at the final report, you'll note that there's broad interest in that, but this is a national issue. It's beyond the scope of what this work group can do. You all can say you would like someone somewhere to address it, perhaps your local or your state elected officials, but it's not something this work group is going to be able to make recommendations to our state legislature about. But maybe you'll surprise me. Maybe you'll come up with something about that. So we're not going to talk about that second bullet today. The third bullet, people were very interested in the detailed information that Donna presented at the last meeting, Donna Sullivan from the HCA, and would like to take a deeper dive into that. And Melanie Smith, I believe we may ask you to sort of take the lead with that. And Donna, I think you've been given a heads up to what some of the questions are. Now, here's the other thing I want to point out about this part of the agenda. Tracy, would you bring up that first picture that we talked about this morning before this meeting? Okay, make that elephant big, if you would. Donna, Tracy's sharing her screen, and if you can see it, there is a big elephant on that screen. Now, I'm going to pull this metaphor to its absolute ends. If I were to rewrite the first issue from the final report, I would not say the implications of shifting to an open access system are not well understood. I would say there's a lot of information about it and people do not understand and trust each other's information about this. I wouldn't say that it's not well understood. I would call out the trust issue, which is an elephant in the room. And I'd like us to go to the next slide, Tracy. And rather than people having blinders on and examining the elephant, coming out with something different, what we've got is some of you have been riding this elephant for almost 40 years. You know how it feels, you know how to steer it, you know how to kick it behind the ears, you know when it needs to be fed. You have a lot of experiential information, and some of you have translated that into qualitative research, which I believe we'll hear a little bit about today, with methodologies that work for your particular way of understanding and conveying information. Tracy, how about that next slide? Others of you have a way of understanding this elephant with a lot of sophisticated research tools, analyses, numbers, and models. And while we don't have a clean juxtaposition between those two things, this is, if you'll excuse my gross generalization, these are two different ways of knowing. And in the past meeting especially, there was a fair bit of distrust about the different ways of knowing about what this elephant is all about. And I dare say that in this meeting today, no one is going to convince someone else that their way of knowing is the wrong way. You can enhance your understanding of how someone with a different way of knowing has come to understand what they do understand. And that will be my objective today. If I hear people seeking information, that's great, or seeking understanding, that's great. If I hear people saying, or either closely veiled saying, I think the way you are approaching this is a crock of elephant punky, I'm going to call you out on it. Because what we're trying to do here is get a full picture of that elephant so that Manny can say what he believes is the right thing for the commission to say to the legislature. Okay, with that as a bit of school marmishness, let's move in to the first part of the agenda, which is in fact the overview of requested information. And Jonathan, I believe that you are the first one that that came to us and we figured out how to do this. If you have slides and such to bring on board, either Tracy can invite you to share your screen, or you could quickly email them to Tracy and she could bring them up on hers. And it is right now, it is 10:53. So we got 2 minutes to spare. Go for it, Jonathan. Thanks.
Okay, I will be sharing my own screen. I think it says host disabled participant screen sharing.
Tracy, can you make it so he can share his screen?
I just made you temporarily a co-host, so you should be able to share now.
Okay. Apologies.
Jonathan, down on that lower right-hand part of the bar, there's an icon that looks like an old-fashioned projector screen right next to your slider. And if you click on that, all the way down and to the right, there you go.
So I'm sorry, I wanted to do the Zoom option where I'm sharing only part of my screen so that I'm able to see my presenter notes.
Oh, okay, sorry.
And I'm trying to figure out how to do that.
Sorry about that. I gave you a bum steer.
I'm wondering if someone else is more ready, they could go first. Or am I it? Oh, you're muted, Martha.
I said we have 2 minutes, so we can give you the time.
Okay. Okay, I think I've got it. Can everyone just see the slides so that I can read the notes without being distracting? Okay. Okay, thanks for bearing with me. So again, my name is Jonathan Proxwijk. I'm the Public Policy and Grants Manager for Cascade AIDS Project. We're the oldest and largest HIV services provider in Oregon and Southwest Washington. And in Washington State, we serve 4 Southwest Washington counties: Clark, Cowlitz, Skamania, and Wahkiakum. And I'm here today to present some research that I've compiled on 3 issues that I think are really at the center of this work group's efforts. The relationship between single tablet regimens and medication adherence, the relationship between medication adherence and healthcare costs, and the effectiveness of prior authorization. So the first of those research questions, if you will, is basically, do single tablet regimens help people living with HIV, and especially Medicaid members living with HIV, stay adherent to their medication? And the research suggests that single tablet regimens, STRs, do mean better adherence for patients facing barriers. The first study that looks at this is this 2016 article from the American Journal of Managed Care. It looked at about 15,600 Veterans Health Affairs patients over a period from 2006 to 2012 to see patients prescribed STRs versus patients prescribed MTRs, what their outcomes were in terms of adherence, as well as some other outcomes like hospitalizations. And they did find that STRs were associated with higher adherence rates, decreased hospitalizations, and more patients with an undetectable viral load. Similarly, a 2020 paper from AIDS Research and Therapy looked at about 4,000 Medicaid members over an 18-month period in 2015 and 2016, and found that among Medicaid members newly prescribed HIV treatment medication, those who were prescribed single tablet regimens were significantly less likely to discontinue therapy and had greater adherence and persistence compared to multi-tablet regimen initiators. Finally, the last study that I want to talk about in this section is a meta-analysis. So looking at other studies, it looked at 8 observational studies about the relationship between single tablet regimens and adherence, and found that STRs were associated with a 63 to 72% higher level of adherence than multi-tablet regimens. And the authors of that 2019 meta-analysis noted that their findings are consistent with previous findings, the body of evidence on this issue. So they wrote, the results of their analysis are consistent with those of previous studies that demonstrated significant benefits of STRs compared with MTRs. So if we know that single tablet regimens help people living with HIV stay adherent, we know that limiting access to them will result in some non-adherence. And so that brings us to this second question, which is, does that non-adherence have a cost? Because I think to know, I think we need to know that in order to do a proper cost comparison, with the cost of offering open access to single tablet regimens. And fortunately, there are studies about this. So a 2019 study published in the Journal of Managed Care and Specialty examined medical and pharmacy claims data for about 2,000 patients over a period from 2007 to 2016, and found that better adherence among HIV patients was associated with significant inpatient cost savings, things like fewer expensive hospitalizations or ER visits. By the way, I imagine that Manny and Tracy will want this presentation, and I have the citations for all of these studies, so you can look at them on your own at a later time. I know it's a lot of information. The second study related to the relationship between adherence and healthcare costs was this one, which appeared in the journal BMJ Open in 2018. It looked at a number of different disease groups to see what the cost of medication non-adherence is. Regarding HIV and AIDS specifically, they found, so this was a systematic review, a meta-analysis, or a lit review basically, and found 3 studies that related specifically to HIV and AIDS, and they were able to identify that the range of the cost of non-adherence for people living with HIV or AIDS ranges from, you can see there, about 17,000 to more than 30,000 per year. Finally, I wanted to talk about what the research says about prior authorization, because in a way, if prior authorization works, the other issues I've talked about are less important, because if prior authorization works, then anyone who needs a single tablet regimen would be able to get one, stay adherent, and not incur those high healthcare costs. So here we're going to leave the academic literature behind and turn to other sources. Specifically, a survey I thought was really helpful that the American Medical Association did of its members related to PA. They just did this in December 2020, so it's really recent. And they asked 1,000 practicing healthcare providers who, to qualify for the survey, needed to be completing PAs during a typical week of practice. And one question they asked was, for patients whose treatment requires PA, how often does the process delay access to necessary care? This is a question we're asking in this group. And an overwhelming majority, 94%, reported care delays, with more than half saying that the PA process often or always delays access to necessary care. AMA also asked survey respondents how often issues related to the PA process lead to patients abandoning their recommended course of treatment, kind of worst case scenario, especially for people with HIV. Still a large majority reported, 79% reported that it can at least sometimes lead to treatment abandonment, with about a quarter, the two top sections there, saying that the PA process often or always leads to patients abandoning their recommended course of treatment. And then I don't have a slide about it, but I just wanted to note, like, AMA is a generalist organization, but the American Academy of HIV Medicine, which is the professional association of HIV specialists, concurs with this. As an association, they have a policy statement that's available on their website, which reads that prior authorization restricts patient access to life-saving medication, increases healthcare costs associated with delayed treatment, and stymies efforts to end the HIV epidemic. So in conclusion, what the research suggests and what the provider survey I just talked about suggests is that single tablet regimens are associated with better adherence for patients facing barriers. Better adherence is associated with lower overall health costs, and prior authorization creates barriers. And I do just want to conclude by saying quickly that none of this is new. About all of these issues, from PA to single tablet regimens, there is and has been a consensus among experts. So leading HIV advocacy organizations across the country are in consensus about the relationship between single tablet regimens, adherence, and health costs. The orgs whose logos you see here, AIDS United, Black AIDS Institute, Latino Commission on AIDS, San Francisco AIDS Foundation, all signed on to a letter to the Healthcare Authority last year, where they wrote that providing open access to single tablet regimens saves lives and fiscal resources while maintaining a clear focus on health equity. And then the top row here represents federal agencies responsible for ending the HIV epidemic. In 2016, all of these agencies, the CDC, Center for Medicaid and Medicare Services, Health Resources and Services Administration, which oversees health centers, issued a joint informational bulletin on opportunities to improve HIV prevention and care delivery for Medicaid beneficiaries. And in that document, they recommended adding single tablet regimens to preferred drug lists, removing step therapy requirements, and designing their prescription drug formularies to minimize potential barriers presented by utilization management techniques. So I did just want to note what authoritative sources are saying on these research issues that we're considering in the group.
Jonathan, thank you very much. I'd like to open up for, I'd like to say we have time for 3 questions. So if you have a question, please raise your hand using the little raise your hand icon. And also, again, if you're interested in making a point about your own point of view, that's not what these questions are about. If you are interested in knowing more about the studies, remember, Jonathan's going to let us post them with all their citations. If you have insight into things like methodologies and you're not making that point in order to attack methodologies that Jonathan himself didn't participate in, that's not something we want to do. But if it's an interesting point about how do people think about these kinds of studies, hey, let's hear it, okay? Who's got their hand up? Tracy, will you help me out with this here? Well, I see Carrie has her hand up this way. We can do it this way as well. Carrie, why don't you go ahead? Yes, thank you.
You mean Carrie Morris? I just want to make sure.
Carrie Morris, yes, Carrie Morris, yes, thank you.
So Jonathan, I just want to clarify on the number that you provided. I believe it was 16,000 to a little over 30,000 as an ongoing cost. This is just on the ARVs, correct? It doesn't include the other medical issues that may arise or the other medical issues the individual will also be juggling, or does it would it also include support services, food, other housing as they become more disabled that they might also have to depend on at the state cost? I'm just wondering if this is just for the HIV medical, or if has anybody done any long health impact on a community or on our state for not providing? And if they have, does that include new infections that are tied to that individual for not getting the proper treatment? That was a long one. Sorry, Jonathan.
That's okay. My understanding of that study is that it's just looking at additional, it's looking at claims data. So things that aren't captured by claims data because they're not reimbursable by insurance or Medicaid are not going to be captured there. I think it's a good point that there are costs that aren't accounted for in that kind of accounting, like support services that may or may not be reimbursed for that patient, and then like second degree costs like transmission.
Okay, we have time for 2 other questions. Now, I didn't mean to dissuade you from asking tough questions. Okay, Jonathan, thank you so much. And thank you especially for giving us the information and the citations. We'll make sure those get up on the website. We had a few glitches with the website last week, but we'll make sure it happens this week. Thank you. Carrie from DOH. I am going to riff here, and if I do it wrong, you're going to tell me I'm wrong, okay? Carrie has some people who she's brought to this meeting, and I see some of you here, welcome, who have experience working with, for lack of a better word, another way to slice and dice this, rather than saying, well, let's just go to a single tab regimen, or let's just make sure we do it this particular way. I believe that Carrie's presenters have experience with pilot programs that allow for different ways to access meds that maybe we should think about. Carrie, did I get that right?
That was pretty darn close for like one little sentence that I shared with you. So hi, good morning, everybody. The only thing I would maybe add to that is that the models you're going to hear about is really some innovation in King and Pierce County, where we've kind of integrated social and healthcare services together to offer a different type of care delivery that's just meant to wrap around more vulnerable populations. And so we thought it would be helpful for this group to hear that we are doing some work around this that seems to really overlap with the population that's being discussed mostly in this setting. And so there might be some opportunities to take a closer look at those models and whether they would be something we would want to build on, or just have more awareness about, how we're trying to deliver care differently to be able to serve these populations in a more meaningful and effective way. So took up all the time. So Martha, do you want to tell me how I can help? You're muted.
Sorry. Go ahead and introduce your folks, and we know they have a short amount of time. So thank you.
Great. So we have a few presenters today. I invited staff from King County's HIV Max Clinic and Pierce County's HIV Max Clinic. And so Martha has allotted 5 minutes for each location. And so they're going to provide some information about what it's like to work in their clinics. So I have Evelyn Manley Rodriguez from the Pierce HIV Max Clinic, and Mark Fleming from the King HIV Max Clinic. And so I think what we're going to do is Evelyn has some slides. So I'm going to ask Mark to go first while I work with Evelyn to get her slides up to Tracy. And that way we can kind of have Tracy advance for us. How does that sound, guys? Great. So we'll have to unmute Mark. And I also just want to say, we're going to, the information sharing is going to be a little different. Evelyn has slides. Mark, I'm just going to be asking some questions, and he's going to just provide information in more of a dialogue fashion. So just so you guys know what you're coming into. So Mark, are you able
I'm
to?
here.
Great, great.
Hi,
I just
friends.
love Zoom. Well, Mark, could you just say maybe a sentence or two about what your role is in the clinic?
Sure. Well, let me just do Max Clinic real quick first.
Yes.
So Max Clinic is an invitation only, incentivized clinic for folks with HIV, where basically the standard medical model has not worked. And so Max, we're kind of throwing the maximum at folks to see about engaging folks in care and hopefully having better outcomes. I'm a program manager. I work with HIV relinkage, and then with Max Clinic, I'm a non-medical case manager and also do a bunch of administrative stuff with money for them. So there's that. And I know that Matt Golden is on, so feel free to sing out if I miss anything, Matt, who's one of the providers.
We are so lucky, honestly. The Department of Health, we are really investing in these models, and same with public health and Pearson King. And they have such commitment of all the partners. So we have so many great people on today that can speak to it in only 5 minutes. So I'm going to just jump in with Mark, and just if you can provide a couple of use cases about impacts on how the prior authorization process with healthcare authority has affected kind of your guys's model or your ability to provide care.
Right. Well, we're pretty lucky. We partner with Madison Pharmacy, Madison Clinic Pharmacy, and most of our folks are on a 2 pill a day. And we have ordered Biktarvy, we have ordered some other stuff, and the prior authorization hasn't always worked, of course. However, most folks do okay with a 2 pill. I have HIV myself, and so when I talk to our folks, who really are probably the most marginalized folks I've worked with in 30 years, there's usually substance use, mental illness, and homelessness, as well as other stuff. All of the broken systems in the world just kind of come right in and intersect, not to mention trauma. And when I talk to folks there, sometimes they're saying, oh, I have a friend, he's on this 1 pill a day thing. What do you do? That's what I'd like. And I say, well, that's great. Talk with your doc, see what's available. How do you do with taking your meds, which a lot of our folks don't do so well. And we have a conversation about how long the medication lasts in somebody's system, and that for some folks, taking 2 pills once a day is actually a better option because they miss doses. So for a lot of our folks, it works out pretty well. And there isn't usually a huge delay in getting people their meds, but if they are really wanting to do a 1 pill a day, we have to do some juggling. And our folks have oftentimes a lot more priorities than a 1 pill a day regimen, honestly.
Yeah, I would just interject here that
Please.
I think this has had virtually no impact on our patients, and that the barriers to people getting virally suppressed in our clinic, this isn't it. It's not even like on the list of important barriers. The homelessness is a huge barrier. Mental illness is a huge barrier. Substance use is a huge barrier. 2 pills once a day versus 1 pill once a day is trivial. So I don't think this has been an important factor at all.
I could see how it would be more of a factor, say, at Madison Clinic or with private providers. But
I actually can't, but
yeah.
you know, I think that
on
pill
that
burden,
too, once you're done.
yeah, okay. I think that pill burden is sometimes a barrier for patients, but it's usually people who have many comorbidities. And so it's not so much that the HIV is the 2 pills versus the 1 pill, it's that you also have many medical problems, right? You have heart failure. And so now you're not supposed to be on a whole boatload of meds for that. You're diabetic, right? Then it begins to be a major barrier. And occasionally, you are looking for how can I decrease any pills you possibly can. But in those instances, it's not usually the HIV which is driving the pill burden. It's their other medical conditions which is driving the pill burden.
If I might interject here, we aren't actually going to be looking specifically at single pill versus multi-pill and which works for which populations better. We're trying to gather information. We're not going to prove anything to each other here. So that's helpful to have these perspectives, but we're also looking at things like pre-authorization and then this underlying issue that several of you pointed out. Are there ways of overcoming other barriers that affect both of those things? Pill regimen, authorization. So I believe Shirisha had her hand up.
Yeah,
And Matt, if I cut you off too early and you have more to say, please come on back in.
Yeah, I guess if I want to stay within the lines here about what we're saying, I'm the medical director and one of the providers at Madison Clinic. And we do have, as part of that differentiated care model and that spectrum of Max and then Madison, which is the regular appointed clinics, we also have a mod, which is people who don't get invited to Max, but are still struggling with adherence and making appointments. So we have this moderate needs clinic. And we're, all of our Medicaid patients are obviously under the same constraints in terms of our 2-pill regimen being the main one. And, I agree that there's lots of other issues about adherence. I'd also want to point out that we can successfully treat people in all of these clinics, Madison, Max, Mod, for hepatitis C successfully, which is 3 pills once a day, and have shown success with that. So in terms of a single tablet regimen, I know we're not trying to make that argument, but I just think it is doable. I think when there are other constraints in terms of, or other factors that affect adherence. I think when we used to have lots of pills, it used to be a lot more complicated and food requirements. So when people had 3 pills a day, and particularly with the protease inhibitors, I think that there were challenges with adherence. Now with the newer regimens, I think it's made it a lot more of even an easier time in terms of 1 versus 2 pills, because there's not a lot of drug interactions or food issues. So I just want to point that out. Like if you're on other mental health meds or other meds for comorbidities, there's not so many issues around the timing of those with these newer integrase inhibitor regimens.
I'm going to jump back in here quickly, and I just ask Mark one more question, and then we'll jump over to Evelyn. Mark, the other thing I wanted to have others hear about is the role HIV case management plays in the model, if you could.
Okay, so in Max Clinic, we have both non-medical case managers and medical case managers. The medical case managers are through Madison Clinic, and having medical case managers who can deal with insurance, helping navigate a variety of systems, including housing, which is a mess, is super helpful. And then those of us who are non-medical case managers provide incentives, talk with people about adherence. I think there's a value in having people who are actually not medical or social workers providing stuff to build relationships. And the patients, I think, historically have said one of the things they love about Max Clinic is that there are relationships with providers, with social workers, like people feel cared about and held in a good way. So between the 2 models, we try and just cover folks' needs, and it seems to be working pretty well. That's not going to get into all the nuances, but there you go.
That's helpful. Thank you. Anybody else have questions for Mark before we open it up for Evelyn? Okay, well, I'll keep an eye out for hands too. And Tracy, can you just confirm that you got Evelyn's slides?
I didn't get any slides, but I did make her a co-host so that she can share them if she wishes.
Okay, great. Well, hi and welcome, Evelyn. Thank you again for coming. And Evelyn also wanted Shauna Applin to participate with her and kind of the information she's sharing. So I'm opening up that presentation option as well. And I'll just, Evelyn, could you just say a thing or two about what your role in the Max Clinic is before you dive in?
Yes, good morning. Thank you for having me here and inviting me to share the Max Clinic. My role at Max is to supervise a disease investigation specialist, as well as bring a health and racial equity lens to the work that we do in Max around policies, procedures, protocols, and bring in other public health strategies to the work. Great. Can you let me know, Carrie, if you can see my screen?
Yeah, it looks great. Yep.
Okay, so I'll get started. Thanks for the introduction. So my role here in Max and at the health department is I'm the STD HIV program coordinator and part of the Max team. So Pierce County Max launched in 2019 as a collaboration between 3 agencies. That's Pierce County AIDS Foundation, Pierce County Health Department, and Community Health Care. The goal of the clinic is to provide multidisciplinary interagency support of high-risk people living with HIV who are not engaged in care and or may not be virologically suppressed. Max is housed within Community Health Care's entity alongside Ryan White Clinic. And this is a walk-in model. This is what others have shared in the past. And it offers access to essential needs items, basic incentives when health goals are reached. So it's incentivized. We have a multidisciplinary team that includes 2 staff members from Pierce County AIDS Foundation, a case manager, and a peer navigator. From the health department, we have a disease investigation specialist and community health care staff, a registered nurse, 2 HIV specialists who provide HIV and primary care. And some of the successes that I like to highlight is that we currently have 57 patients enrolled, with 19 that are virologically suppressed. They're also very successful in getting people housed, seeing patients successfully complete rehab, and joining patients in achieving other health goals, including graduation from Max and transitioning back into a Ryan White Clinic model. We conduct field visits to relieve individuals who are out of care, offer case management services, even out in the field. And transportation has been huge. Pierce County is very rural, so that's always been a barrier to care. And we also work on engaging Max patients who may not be as compliant with care. In 2021 / 2022 proves to be very exciting time for Max Clinic as we expand to provide outside our clinic medical model, more of a mobile health team to deliver healthcare to patients in the community. And one of the questions was, how does our approval impact, what does the impact have on HIV drugs? I have a case I'd like to present. And Shauna, make sure that you step in there and help out or add anything you'd like to. This is an MSM individual who's on Medicaid, high risk for kidney disease or bone loss, needs TAF-based products for risk reduction. The only current regimen right now is Genvoya, a boosted regimen with many interactions and lower barrier to resistance. The desired regimen would be either Descovy, Tivicay, or Biktarvy due to the reduced kidney harm or bone loss and having higher barrier to resistance. This example right now is that there may be some potential inequities because if an individual, an undocumented person or uninsured or privately insured individual can get the desired regimen that a Medicaid patient cannot get. This can lead to health inequities for Medicaid enrolled individuals. The current solution that we're working with undermines providers' medical recommendations due to the cost and decreased trust between patient and provider. This does not support the patient-provider joint decision-making for the best patient care and outcome. Sean, is there anything else you'd like to add before we move on to questions?
Yeah, I just thought to Martha's guidance on this conversation, if I could just focus on two main elements to what Evelyn just shared. I think the equity and access is the biggest complaint that we have, just that our Medicaid population is not able to access meds that other patients are in the state of Washington. And that feels discriminatory. And so that feels really important to us, not talking one pill versus two pills here, but more equity. And then the second piece is prior authorization. We don't have a system like Madison where we have pharmacists and a big team of people who can help. And so having to do prior auths and this step approach is really burdensome. It ends up on me because we are very short-staffed, or even more short-staffed because of COVID. And so that's another barrier to getting patients on medications in a timely manner. So I would say in our MAX model, where we are serving the most vulnerable patient population, those are the two main things that I wanted to highlight with the commission, because it is inequitable and it's not fair to our patients on Medicaid.
Okay, I'm going to step in here. We're basically at the time where we were hoping to take a break, and we do. We will take a break, but we have at least one more set of informational things to go through. So I'd like to invite, do people have questions? Again, explanatory questions help me understand this kind of questions for those who've so kindly stepped in and right at the end of the week, last week, offered their expertise to us. Just go ahead and raise your hand. Melanie's got her hand up.
Hi, thanks, Martha, and thanks everybody for all that really interesting information. I think my questions were probably for the earlier presenters. So Jonathan had listed a bunch of different research that had been published in peer-reviewed journals about adherence to MTRs versus STRs. And my question is, I think for maybe the couple of doctors we have there been other studies that we just didn't see that were done in a, sort of a rigorous way to demonstrate the opposite of that? Because I think that particularly for the non-docs in the room, I think it would be really helpful to understand sort of if there's a methodology behind that. And then secondarily, to the point that some of the folks that are coming into these clinics are really complicated health needs, and they may have things like serious mental illness or other barriers. I think it's really important to maybe sort of, they're not separate people, right? Like the same person that has the barrier of mental illness also might have difficulty with adherence. That's been some of the research that I've seen that shows that not only are people with mental illness more likely to have or disproportionately have HIV, but that because of the nature of the mental illness, that also might have an interplay with their adherence to other medical care. So just curious about both if there's any cited research that you can point us to that that we can review, and then also just talk a little bit about when you said, I think it was Mark that said that's not the biggest barrier they have these other big barriers, but it's all just one person, right, with all of the barriers. So maybe just talk a little bit about that would be super helpful. And thank you. Sorry to pick up so much.
So first Jonathan, is that correct, Melanie?
No, it was really for, I think it was Matt Golden and
okay.
Mark. I can't see on my screen anymore.
Okay.
Sorry.
Okay. So Matt and Mark, and then we'll move on.
So for the single tablet regimen versus multi-tablet regimens, most of those studies are old and pre-integrase inhibitor. So it's not clear to me that that information is germane. The sole study that I am aware of from the integrase inhibitor era, which I can give you guys a link to it, did not show any difference between single dose and multi-dose, or single pill and multi-pill regimens. I'm not saying there isn't an individual where that would be important, but in the study, this data don't support, I don't think in the contemporary period, that that's true. Although we certainly could use more data on that particular topic that's more up to date. I agree with you that it's the same people who have mental illness and are struggling with their adherence, that you're looking at a panoply of problems. I think the point that I was trying to make is we look at this spectrum of challenges that people are having to adherence. This isn't very high on the list. And the things that are the bigger ones where we need new investments are not so much, in my experience, spending more money on pharmaceuticals. It's housing, it's better access to mental health care and substance use treatment and other things.
Can I ask
Thank you. Shirisha? Oh, Melody, did you have a follow-up question?
I do. I guess my question is, on the, there's things we can fix for people, individual societies and systems, and there are things that are just sort of, we're not able to fix easily. So I guess my question, a follow-up question to what you just said is, I understand maybe not the only issue, but, maybe just worth thinking about, maybe this is for this group to think about what we can impact and what we can't, right? Given that we've struggled with all of these systems for lots and lots of people. So if there's a smaller fix that works, that gets us to where we need to go with some folks, I don't know. I just think, I would be interested to think about, maybe, and this is less of a question, but I think it is a question, like, what are the things that, of that list you just mentioned, are there things that can be fixed, right? Like if their underlying mental health is the barrier, that might not be something that this work group can address.
Excellent point, Melanie, but it is something that this work group could talk about in the report. Shirisha, and forgive me if I'm not pronouncing your name correctly.
Oh, no, that's correct. I think Matt really covered it, but just going back to Jonathan's data that he presented, the studies were review studies that looked at these older regimens. So looking at those studies, there were 3 pills on average that were mostly protease inhibitors. So adherence was more challenging with those medications. So I just want to point that out, that the studies were a little bit older before we started using mostly just integrase inhibitors. And so it's not necessarily a comparison of what our 2 pill once a day versus our 1 pill once a day is now, given the timing of those studies.
Okay, thank you so much. Earlier on, I showed you the picture of those elephants, and Everett, I would like you to invite you to go ahead and speak about an experience you have riding that elephant briefly. And then let's move on to the final bullet in our information section. We'll take a break and regroup.
I was like, oh, I don't know where she's going with Everett and elephant.
Maybe you weren't here when I had that up on the screen.
No. I was here for the. I'm just making a fat joke. It's okay.
Okay.
Okay. But my latest labs from my annual physical, I look great. Okay. So I'm the executive director of Blue Mountain Heart to Heart. I'm also a commissioner on the state commission, working with Manny and Stephen. But Blue Mountain Heart to Heart has been in existence since 1985. We've been a Ryan White Part B provider for many years. We have a very high acuity patients, clients that we serve out here in a 6 county-wide catchment in Southeast Washington. And the vast majority of our clients are on Medicaid. They are high acuity according to DOH's criteria. We have a more than 95% success with our clients in getting them virally suppressed, despite the many, many challenges that they have. But I would like to just speak a little bit about 3 clients in particular. They're all fake names, except for the ones that are deceased. So Robert was a longtime client of ours, lived with HIV for about 26 years, had bone cancer, was very difficult to diagnose. He was complaining about pain in his leg, and the doctors, his HIV and his PCP, his HIV specialist and his PCP both dismissed his claims, thinking that he was trying to seek pain medication because he did have a past history of narcotic abuse that had been resolved, with recovery for at least 15 years, but it was still kind of on his medical record. So it wasn't until he stood up to get out of bed one day and his femur broke that everyone understood he did in fact need a lot more support. That's when the bone cancer was diagnosed. At that point, he had a CD4 count under 200. This is because he had rejected 3 classes of HIV medications. And so he was on a very expensive 2-pill regimen at that point. He definitely had housing. He definitely had mental health support. What he didn't have was understanding providers in the region. There's no HIV specialist in Walla Walla. There's no infectious disease doctor in Walla Walla. They have to go an hour just to see an infectious disease doc, 2 hours to see the HIV specialist. So I totally agree that sometimes these pill regimens are not themselves the biggest barrier, but they get compounded into other problems around stigma, around past medical experiences that people have had, around communication, and certainly, yes, around mental illness. Clayton was another of my clients who had methamphetamine addiction, and he showed up in the emergency department a lot. The methamphetamine addiction meant that he was not very adherent to his medication for HIV, and that he too became insensitive to one of the medications, and then he was put on a 3-pill regimen that gave him what he said was very bad nightmares and insomnia. This created basically a cascade for him that over a period of 6 months, he became more and more psychotic and divorced from reality, and he committed suicide a few years ago. So I understand it might not have been possible to, get him on a different pill regimen given where his mental health was at. But again, he was a case that, the providers and the social workers at Blue Mountain Heart to Heart, we couldn't find a solution for him in time. But I think, asking someone with psychotic features to handle 3 different pills a day, in addition to other medication that he was on, was a bit too much of a stretch for him. Then we had Mike, who was diagnosed late, didn't realize he had HIV until he had multiple lobe pneumonia infection. And at that point, his CD4 count was 59. He was terrified because his health was so bad. And so I think having to start him out on a multi-pill regimen in order to see if he would fail first would have been really unnerving for him, in addition to him just trying to adjust to his diagnosis. These are just 3 cases of folks who, I've seen over the years. We have about 40 clients right now, and they're all pretty well managed. There are times when people have kidney failure, and that means they need to change their medication, or I've had women fleeing domestic violence and they didn't get their medications in time, and then the pharmacy gave them trouble in trying to get refills. So then we have to go to a charity program with the pharmaceutical company in order to get extra medication before the refill date. There are lots of ways in which our system doesn't understand the given situations of a person in crisis, and the case managers, and I know many of the providers, do everything they can to try to help people. But on the ground out here, after 11 years in supporting people, I'm very concerned that if we just simply restrict medications and take the conversation away from people with their providers, that we're going to have more of these incidents with folks. And, you know, Clayton and Robert can't speak for themselves anymore. And I wish they were still with us. So thanks for listening.
Everett, thank you for that. We're really running out of time here. So I'm not sure I'm going to pronounce your name properly. Sharisa, let's have a question, and then we're going to move on to the next piece. We're going to take an ultra short break and come on back.
You know, I'll cede my time for a question. I'll just type my response. I'm from the Healthcare Authority. I'll type my response in the chat. Someone else can speak.
Terrific. Thank you. And I think if we've done anything here, I just want to offer a quick congratulations. We're really understanding better the nuances, that it isn't just this one thing or that one thing or one way of studying it or another way of studying it. Thank you for that. I really appreciate the spirit within which this information has both been offered and discussed. A group of folks were so grateful to the people from the HCA for really shining a bright light on the fiscal analysis that they had to do, they're required to do in order to take a look at the, I'm not sure I'm going to use the right word here, but the rulemaking a while back. And Donna and company provided that information at the last meeting, and people have had time to think about it, process it, and thank you so much for making all that information available to us, Donna and company. We really appreciate that. And there are some people who would like to take a deeper dive into understanding better from whence assumptions and numbers came in that fiscal analysis. And Melanie, you may not have seen my note to you. I am not sure that Tracy has the questions. I know she does. Okay, Tracy, if you could bring those on up, that'd be terrific. And then I am not recalling exactly who it was who worked together to put together these questions, but I wonder if we could ask our colleagues at the HCA about these. So up come the questions, and if we could make it full screen, that'd be terrific. So I'm going to ask for one of you who was responsible for this to walk us through what this is, and then ask the questions again in the spirit of understanding, yeah.
I'm happy to start, and then others can join in. So we thought, a couple of us just thought it would be really handy to just put together, you know, essentially what this formula looks like, along with the questions of each sort of part of the formula, right? So, you know, this is actually a pretty simple formula of this many people costing this much money or about this. And so, but really to help us just frame this discussion. Sorry, I'm not very eloquent today. We just started use this as a tool to help us understand how all of these pieces fit together. So around the average cost of the single tab regimen, you know, we wanted to know, you know, what are the STRs that are included in this cost? What are the assumed market shares of each STR? And then what is the time frame for this assumption? So those were the three questions we had around the average STR cost. And I'll say there probably are more questions in this, but this is just what we came up with. Again, the same kind of questions for the MTR cost, the average MTR costs, right? So which ones are included in the cost estimate? What are the market share assumptions of each one? And then what was the time frame of the assumption? And then this is how many Medicaid beneficiaries are currently on our MTRs. This is our understanding is 3,151. And then the estimated number of MTR users who will switch if this policy is somehow altered or changed. So what is the average persistency of patients on MTRs? So in other words, how many people would indeed switch to the STRs, or how many people are thriving on the MTR regimen and they would not make the switch? And then that's the whole, and then the years of cost of impact, that is just because of our biennial legislature. So, you know, what are the 2-year costs? So this was just the framework that a couple of us started talking about. These are the questions that we thought were really important to sort of dig into on this formula, but eager to hear what other folks have to say. Carrie was involved in this table as well, so I'm going to put her on the spot a little bit and see if she has anything to add to what I just said.
And Melanie, I'd like to invite you all to say why you had this question. In other words, the 60% on estimated change. Do you have a question about that because you think maybe it's different? So.
Yeah, and I think this comes from the conversation that we had a couple of weeks ago. Maybe it was the last meeting, so I can't remember. Where Donna put up those great numbers about the cost estimates that the healthcare authority had used when thinking about this. And so I think that they had made an assumption of, I think it was 60%, but it could have been a range between 50 and 70, something in there. I don't think the forms I don't think the presentation is back up on the website yet. So I think we remembered it was 60%. And we had a conversation about, the role that advertising plays in this, but really we wanted to get a better sense from, what the science and the data says about how oftentimes people will switch their medications from something that is working for them, right? So if it's not working for them and they are going through the process, can we find out how many people are going through that process? But also, what is the data say about other similar drug protocols when that might be, a lifelong regimen that people might need to switch on? So just understanding that number a little bit, because it's so critical to the cost. I don't know, Carrie, did I get all that right?
Carrie, and then I'd like to invite Donna and Teresa to respond if they care to.
Yes, thanks, Melanie. I think you did a pretty good job. This has been just the question all along for me as we work kind of on a legislative, like what is the cost to do this? And questioning, I believe at one point the numbers the legislators were even up to 70%. And I know that's kind of an average looking at other states, but our question is how do we really come to that? Looking at this population, is this population a little over 3,000? Are they all affiliated with an MCO, or are they fee-for-service Medicaid clients? And is there a change in the cost?
Carrie, unfortunately, you are frozen for me. I don't know if you're frozen for others as well. Yeah, you are. Mm-hmm. So we missed about from after, is there a change? And Carrie, I think we're going to need to ask you to find a way to unfreeze. Maybe I'll have to come back in and out. I apologize for that. And I wonder if someone from the HCA would like to respond to this. You certainly don't have to. I mean, these are out there as questions.
Hi, this is Donna. So first, I just want to point out that the numbers that you have showing here don't match what I had in the model that I showed. So I'm not going to speak to the numbers rather than try to speak to the methodology. So I just wanted to point that out. Okay. So we included any single tablet regimen where there was utilization. What we did is we pulled 2019 calendar year 2019 data of all users of any HIV medication, and we identified those that were on single tablet regimens, and an average annual cost was made. And I'm trying to find, I didn't do the analysis, so I'm just reading through what the finance individuals said. So drugs that had no utilization or very low utilization were excluded. And the average annual cost was really a net cost based on, and it was weighted by day supply. So we took into account and it was a weighted average, I guess, to say. And then we identified, those 3,000. And so I have 3,746 people on an MTR regimen. And we identified 1,762 individuals that were on Truvada only. So the model that was shared, they called MTR users, they called people taking Truvada an MTR user, even though Truvada is a single tablet. And they did an overall shift looking at just the multi-pill regimens that were a complete regimen, and then they looked at PrEP separately. So the average cost, like I said, for both STR and MTR was a weighted average of all of the regimens where there was utilization. And then we simply looked at, you know, a what if scenario. What if 10% shifted? What if 15%? What if 20? And I think when we looked at other states that have open access, you know, there was a pretty big range, somewhere between, you know, some as low as 10% of single tablet regimen users, all the way up to, I think one state had more than 90% single tablet regimen. So we looked at the, you know, I think where you're coming up with the 60, as I had said, that the states that reported, you know, their utilization to me, the median, you know, was about 55%. So somewhere between 50 and 60% was where states with open access, that was their single tablet regimen or utilization of all patients on HIV medications. So I think that's where that came from. We looked at just that 1 year's cost. So we didn't look at additional costs that was mentioned. And the 60% that I have is a $36,476,378 difference for the state. So I thought that the document got published that has the model as well as the methodology in it. We did look at managed care separately, but we didn't go into a lot of detail between managed care and fee-for-service because there is a considerable difference in the population sizes.
Donna, thank you very much. And it's always appreciated when somebody has numbers and they get to be on the hot seat to have to talk about them. So thank you for that. Let's take a few questions and then we're going to have the report on the town hall and take a very short break and come on back to do our breakout group work. Anybody have questions?
Donna, can you tell us what the average difference in cost between the MTRs and the STRs were in your analysis?
The average STR cost, and I don't have it for overall, at least it's not spread out here, but for, or maybe it's at the bottom, nope. For managed care, it looks like 25,000 per year for the STRs. And then for the MTRs, it was 12,333. So it's double the cost.
Okay. Thank you very much. Melanie, and then we'll hear from Renee McCoy.
Right. Thanks, Donna. I just have a clarifying question. I'm sorry, I was trying to follow what you said. Did you say that some folks that were on just a singular, just they're on a drug, but they were on one drug, but classified as an MTR because they didn't need the other components? So
no, my finance team just called everything. We were trying to look at MTR utilization for treatment separate from those that were taking it for PrEP. So the assumption was anybody that had only ever taken Truvada were taking it for PrEP.
Okay.
Okay, Renee, can we hear from you about the town halls?
We're still sharing a screen here. All right. Okay, so on September 20th, we had our first town hall. We've got another one coming up. And it's important to note that the town hall, unlike the work that conversation, was that we talk about more about what and that we talk about not how that was weird. We're not recording. I'm getting weird messages from Zoom, but that's
and
okay.
Tracy's working on it. Yeah. And
oh, okay. I'll just keep going. So what we wanted to do in that conversation was to focus on identifying, trying to figure out what the challenges were in terms of access in a broad sense, and how those challenges with and caring for people with HIV and people who are in service to people with living with HIV. It was important also that we come up with some recommendations for improving access, since that was one thing that everybody has agreed on throughout this. You know, as Manny said, everybody, regardless of where you're from, has agreed that increasing access is important. So basically, the conversation revolved around what are those challenges and what are solutions that we can recommend. The greatest overarching challenge was that that people with who are living with HIV need good health care, and it was pointed out over time that for the most part here in Washington State, there's, you know, for most of the people dealing with HIV, healthcare has been good. The problem is that that there continue to be we continue to struggle and continue to be challenged by those people who are the most vulnerable population, those who are people who are, for example, people of color, people who are homeless or unstably housed, people who are dealing with mental health issues, people from immigrant and refugee communities, persons for whom English is not their first language, people who are living in rural areas, and people who are returning from periods of incarceration. And these were all groups that were identified as important. And it was also pointed out that the issues, interestingly, it's right in line with some of the conversation we've been having this morning, that the issues are larger than the complexities of medication. It's bigger than adhering to single doses or adhering to multiple dosage. That such issues included, you know, organizing your medication regimen, moving past language barriers, the barriers that are created by cultural differences. Some of the other challenges that were identified in the conversation were that physicians are hampered sometimes because of the requirements of compliance. I mean, requirements of prescribing meds. Another one was FDA guidance doesn't take into consideration all the other stuff that impact on people's lives as they are dealing with taking medications, such as pre-existing medical conditions. The fail first or step therapy is extremely problematic for providers because it requires this period of trial and error, and that places positive outcomes in jeopardy for the clients. And when it came down to multiple pills, prescribing multiple pills, it becomes even more challenging for persons who are newly diagnosed with HIV. Someone pointed out that having HIV was already a traumatic experience, and it becomes even more so when they're told they have HIV, and at sometimes they are in the advanced stages of the disease, and then having to deal with juggling multiple pills just becomes overwhelming. Another thing that was pointed out was provider burnout, that providers are just getting so overwhelmed with the processes of care that they're just stopping. People who have been serving people with HIV for a long time are just stopping. It becomes a process that is not just overwhelming, but is embarrassing and insulting and offensive for people who are trying to provide care. Medicaid and those who are on Medicaid experience insurmountable obstacles, and when providers are having to go through such insulting and offensive steps just to care for people that they've been dedicated to serve for years in the HIV community, it creates what was called a toxic environment for both the providers and the patients. So it's bigger than just the patients, just the persons who are receiving care, that it becomes toxic for those who are trying to give care as well. It was pointed out that the immigrant community continues to be challenged by limited access because of cultural differences, and that providers are sometimes insensitive to the needs of the immigrant and immigrant community, and that it is difficult for people who have to go through pre-authorization, for example. Sometimes the requirements of getting care doesn't take into consideration that person in the immigrant community who is who it's based on their income, but they may be taking care of a lot of other people in their household who are undocumented and who cannot, that income, using that income as a prerequisite, for example, is unrealistic. There's also pointed out that the stigma of HIV on the immigrant community is, and as well as the stigma of HIV in communities of people of color. Another point was that returning citizens, what I call returning citizens, people who are coming out of periods of incarceration, homelessness, returning to limited income, the absence of familial and community support, and those issues also reduce their ability to adhere to complex and complicated treatment regimen. The toxicity of some of the medications was pointed out as well. That decisions about what medications to prescribe is based on a lack of information from providers about about the toxicity of medication in the formulary, which may be convenient. Some of the recommendations were that we asked people how to respond. What could they think about in terms of responding to those challenges? And some of those were that they reduce the requirements of care providers when they have to prescribe medications. Providers should be able to prescribe the medications that work best for their patients rather than medications based on cost efficiency. Another recommendation was that the formulary include all HIV medications rather than only those that were identified through the fail first or the step therapy process. Another one was that increase in cultural sensitivity training for providers, people who are dealing directly with persons living with HIV. Another was to encourage providers to remain current about information concerning medications, especially the difference between multi-pill regimens and single pill regimens, and how different medications interact. The other was realized that people receiving a diagnosis of HIV late in the progression of the disease are at risk for other health problems, and that again recognize what a traumatic experience that is, and that that some of these ancillary health conditions might require additional medications and additional information. Another was to provide basic information about medication directly to persons with HIV through some accessible platforms, such as Zoom or face-to-face meetings, ways that some of this might be the inconsistency or the adherence and challenges might be remedied by just patient information. And the final one was to identify those who are most vulnerable and aggressively reach out to them to determine from them the best way to increase access to medication, to determine from them what constitutes a quality of care. And it was stated that responding to patient-identified quality of care leads to improved health. It was all about paying attention to what's really going on in people's lives and uncomplicating the care. Our final question was, what's going to happen if we do nothing? And everybody agreed that those who are underserved will continue to suffer, and that persons living with HIV will continue to experience lowered self-esteem and substandard quality of life. So I want to, give you guys an opportunity to comment on this if you want.
Well, Renee, I'm afraid what we're going to need to do is, given that we're almost 25 minutes behind, is invite people, if you have comments for any of us about the next town hall or what you heard in the summary, please, please, please send us an email. We're going to take a 5-minute break, a less than 5-minute break. We're going to be back at 11:15. Tracy, if you would be willing to bring up the PowerPoints about the breakout rooms, we'll dive right into that when we come back together. Thanks. Thanks, Renee.
Cool.
Remember, folks, that we continue broadcasting live. So just a reminder, in case that you want to chat or whatnot, remember that we are still broadcasting live on YouTube. So whatever you say will be heard by people who have tuned in. Okay.
Hi, Tracy. I'm just going to talk directly to you, and as people come back on, they'll hear us. You had asked if we should shorten the time, and I just said no, we'll shorten the report out time, but if people don't come back, we'll have to shorten the time for the breakout rooms as well.
Okay, just let me know, and it's an easy adjustment. I had set up everything in advance so that it's just a one click to get in.
Okay, so folks, those of you as you're coming back on, if you would do us the favor of turning on your video, which you can turn back off again, but turn on your video so we know you're here. If you have both thank you. And then we'll, as soon as we have the majority of us on board, we'll go into the breakout room work. Okay, so we're waiting for Melanie and Carrie and Devin. If you're here, turn on your machine. Thank you, Carrie. Sharisa, I saw you were there earlier. You have the most beautiful background of anybody. Okay. Melanie Smith, are you with us? And Donna Sullivan, I hope you are with us. Okay, let's get started. And Tracy, you may just need to kind of run interference as people come on board and want to know what to do. So at this point, folks, what we're going to do is go into breakout rooms. And because of the short time, and because most of you haven't had a chance, we don't believe, to read the version of the report that was up on the website, we're going to do this in a sort of a brainstorming kind of way. We're going to have 3 breakout rooms where we're going to combine some of the issues. Issue 6, which is in the final report, which is the goals of the 2016 report to end AIDS 2020 have not been met. We're not going to discuss that if you, we're just at this time. Up on the screen is the table we put together at the draft table at the back of the report that addresses which of the issues we believe can offer both a characterization of that issue and options for resolving that issue, which go across the board in a manner that addresses the 3 topics that were in the budget proviso that was given to the LGBTQ Commission to have the work group advise them on. So Tracy, if you could go to the next one. Breakout room 1 will be the issue number 1, which currently is worded, the implications of shifting to an open access system are not well understood. I think I mentioned earlier, if I were to rewrite that right now, I would. Breakout room 2, and I believe we decided, Manny, that I would do that one, or did you want to do that one?
The number 1?
Yeah.
I can take it.
Okay. So Manny's going to do breakout room 1. Breakout room 2, actual costs need to be comprehensively analyzed and understood, and lift the veil on drug pricing, drug costs, and the role of rebates. I'll take that breakout room. And breakout room 3 will be about the issue currently stated this way: pay attention to those who are or have been left behind. And issue 3, the fail-first system may create obstacles that have implications for both individual and public health. If you could go to the next slide, Tracy, thank you so much. Tracy's going to run interference for us in the chat room if you have technical issues while you're in your group. Oh, I'm frozen. Okay. Next slide. Here's how we're going to do these breakout rooms. Your focus questions are these. Does the report adequately characterize this issue or these issues? If not, how could it be improved? Generally, we will do the wordsmithing. Are there more options that could be listed for addressing this issue? If you have time, you may not have time. Any that are listed here that need clarification, I can guarantee you won't have time to go through all those. But what we will do is open the Google Doc back up, and you are welcome to just pour your heart out in that Google Doc, but this is an opportunity for us to hear from each other. The timing is this, and this is important. When you first go into the work group, your facilitator is going to ask you to look at everybody on the gallery in your breakout room and just think silently, given that time is short, what is the most important thing you have to say about this, that you want others to hear and that you want to say out loud. We'll have a discussion. The facilitators will do whatever they care to do to make sure everyone's heard. 5 minutes before the close, Tracy's going to let us know that we need to stop, and the facilitators will take a break with y'all and say, what is it we're going to report to the whole group? Then we'll come back. We'll have 20 minutes to report out in the full group. We'll close in time to have a little bit of a wrap up and remind you all of next steps, and we'll say goodbye at noon. Okay. So Tracy, if you would open up the breakout rooms, and here we go. Go ahead and join where you'd like, wherever you'd like to go. And Tracy, if you could, I think you can assign Manny and Renee and us to rooms, if that would be good.
Just let me know if you need me to assign you to a room. I can do that as well.
I'm still trying to decide, so I'll take myself shortly.
No problem.
Tracy, I think we're at 5 minutes, aren't we? Shouldn't we be wrapping up? You're muted, my dear.
Sorry. No, we're at 11 minutes at the moment.
Okay. All right. I think we should wrap up sooner.
Okay.
So
I can. I'll
why
send a
don't
broadcast.
you give us a 7-minute? Let's see. So it would be at what time would we be?
11 minutes from now, which so 52 is what I have here.
Okay.
Is when we
well,
would come back.
If that's what we said, let's stick with that.
Okay. I have a timer set to remind me to tell you guys at 5 minutes.
Okay. All right. Thanks.
No problem.
Welcome back, everyone. I hope each of you had conversations that were as rich as open as ours was. I got to say, breakout rooms are brilliant. Manny, you have the good fortune of having worked with breakout room number 1. So I'm going to ask you to report out, and I'm going to ask everyone to please be a little patient. Let's go till 5 after. So give us your quick hits, Manny, and we'll move along.
Sure thing. I'll try my best to summarize to the best of my abilities. It was a rich conversation. I also have to to say that it is sometimes frustrating that we don't have enough time to go in depth into these, and that's across all of these conversations. So please know that we know that the facilitating team knows that, and that there are many ways in which you can reach out to us and engage us in conversation so we can continue adding things and adding ideas. So please keep that in mind. So with that said, also, a note that I will share later on today the link to where you can send your feedback on each one of these recommendations. Please do use that link. We want to know what you think, how you look at this, because the point of these conversations is that we have community input. So it's not for me to come up with the things, it's for me to present what the community has come up with in terms of solutions. So please keep that in mind. And remember that this is our work, and none of us, Martha or Renee or Tracy or myself or Omar when he was with us, none of us feel like you are, against us or attacking us or anything like that. We are the conveners of a conversation, and we look forward to hearing your feedback and integrating that into the report. So please keep that in mind. With that said, I wanted to share some of the things that came up during the conversation, some of the most important things that my group identified on open access and the possibility of shifting to open access. That it is an issue that is well understood already. So there's no real confusion of what open access is and who it benefits and who allows to have access to the right medication. Another issue that came up, another important issue, is that that cost sometimes is used as an argument, and all that has to do with cost is used as an argument, but there is a will on many groups, including the legislature, to fund whatever program and processes make it more accessible. So cost from the perspective of some members of the conversation and would not be really a quote unquote excuse. Cost is something that can be addressed, and that the legislature has a will to address as well, and even fund. There are some the other thing that came up as an important point is that what we need is not focusing on cost, but actually on what is the best policy to make it accessible. So if we collectively shifted the conversation from this is the cost of funding this program or that program to this is the best policy to ensure equitable access, that would actually address and make it more accessible for people who are experiencing more challenges in accessing HIV medications, and that we should look at shifting the conversation from cost to policies that are good for the people who need the medication. And then when we went into feedback on how the current draft presents this issue and some of the solutions, some of the things was there is some frustration on the part of people living with HIV and people serving the community who lives with HIV, providers and social workers and things like that, that the way in which it's written, it looks like there's a false narrative, or actually it presents a false narrative comparing state agencies, our agencies, to the needs of the community, and the perception of our perception as the facilitators to present this in a balanced way is actually kind of erasing the concerns and the solutions that have already been put forward by the community. So that's something that I want to share with you, and I hope that I'm summarizing that the right way. But yes, the way in which it's written presents a false narrative that everybody's on the same foot and on the same level of access to information and access to understanding, and that everybody comes with the same experience when it's not. There is enough data to go about making decisions, and perhaps in adding one more group and one more study, as we are recommending, might not be the best way, because the data is already there, the recommendations are already there, and the examples from other jurisdictions are already there. So perhaps funding another work group to study issues might not be the best way to go about these. And presenting solutions. It is an issue of public access, so it's not an issue of cost, it's an issue of accessing, and we should focus on that. Then another thing that we discussed was the inconsistency on understanding of fiscal assumptions. So it is perceived by many people in the community, but the majority of people in the community, that our side, the government, is not presenting clear data on fiscal analysis, and that is concerning, and also making people not feel comfortable with the processes that have been used, because so far there has been some inconsistency in how the fiscal assumptions are understood by different players here. So yeah, and then one thing that we talked about is that some people, that the processes that currently exist might put some people at harm and hurt some people, and that we have to pay attention to how that is playing out, so we can go back to the policy and find policies that actually take off that burden on the people who have been hurt by the current processes that the government uses to allow access to HIV medication. There was the voicing of the discomfort by some members of the community, the discomfort of having both the HCA and the DOH being part of the conversation. And that is also coming from the idea or the statement that the community has already had many conversations about this, and that we collectively, we're hoping to move ahead with recommendations, not necessarily to engage these two state agencies on the discussion. So, and I'm not justifying one thing or another. I'm just reporting out some of the conversations that we had, okay? Because as I said to somebody else, I too am government, so keep that in mind as well. The LGBTQ Commission is part of these agencies. And then the other question that was raised is, why is so difficult to make HIV medications accessible in the state of Washington when it's so easy in other states to have open access policies? What is at the heart of the matter? So why is Washington still not having open access when other states with less resources or perhaps with less money to pay for it, or different issues, do have open access? So those are some of the things that I took note on. There's some more details on each one of those, and a couple of others that will be included as well on the report out. And members of my group, if I left out something that you believe is very important, feel free to add it on.
Well, and I'm going to ask you to add it on electronically, because we have some people with hard stops. So Manny, you all will hear some themes here. Mine's going to be a little shorter. The group that I worked with, and I'm going to mix it up a little bit, noted that reminded each other that the objective is to make information available to the commission that can make information available to the legislature. And what is it that the legislature needs? And the more transparency about numbers, it was mentioned several times. And then there was some and how do we actually get to that more transparency? How do we have a better understanding, in particular, of the actually want to use this word, but I'm going to, the veracity or the applicability of the 60% number for switching from MTR to STR. Lots of curiosity around that and a desire to have that show up better and understand it better. Also, a belief that maybe what we need to do is take a deep dive into Washington state specific data, which wouldn't necessarily be a new work group, but would be a funded scientific study. The other thing that was mentioned, and this was quite a revelation, is that how do you leverage the price of drugs? How might you bring down the price of drugs? And it was pointed out that possibly having things on the prior authorization list is the thing that allows the state to have the leverage to say, if you want to be on that prior authorization list, then you got to bring down the price. So that is, I think that's a reality. That's sort of one of those, that may be one of the elephants in the room that we need to talk about. Another issue is if we only look through the cost lens, even if we think ultimately all populations will get dialed in, what happens if we also look through or look first through an equity lens? And we may have different outcomes. Manny, the discussion was not dissimilar to the one that you spoke about earlier. And I'm going to close there and invite Renee to give a nice crisp recap. And Manny's already talked a little bit about next steps. So after Renee speaks, we'll let Manny close us up. And I'm not going to speak again, so I'm going to say thank you so much. This was a wonderful meeting, very helpful. Renee.
Right. I had a wonderful time with some very passionate people. So one of the things we talked about was, I think, was pay attention to those left behind and fail first. And people pointed out that fail first is burdensome to some, but might not be as burdensome to others. And we need to understand that for some, it's burdensome because it takes time and takes energy to go through the process. And sometimes it delays viral suppression. But there are some that it works for, and we need to have a better understanding of why there's an inconsistency in experiences with fail first. That we need data from providers and from clients about what's really going on. One of the things that we need to look at are inequities with other drugs in the HIV formulary, and it was pointed out, and that's when we got really passionate, that fail first is not really that serious. There are other things that are much more important than fail first, such as open access, as housing, looking at ways of causing less burden to providers. It was pointed out that the cost of drugs is not as important as care coordination and risk reduction. When we just look at the cost of pills, that we should move to do it all. One of the things was that DOH pointed out that that it is interested in working in partnership with people as well, and still committed to, and it seemed that everybody was committed to finding ways to support and improve the case management system and identify the needs. One of the things that that was really important that we have transparency about the relationship between pharma and providers, and transparency that was without judgment, transparent over the years, and who needs to do what and why in terms of both public health and pharma. Is that quick enough? I think
yes.
that's
Manny, you want to
pretty much
close us up? I wish we had time to do more here, but Manny, could you close us up? Thank you.
Yeah, folks, thank you so much again. I put the link to where we can continue receiving feedback on each one of the issues. Please refer to the website for the documents themselves. I have also shared some research on different issues and comorbidities and things that can affect adherence. So please check out and keep up with the website. And also, very important, with the transition on staff, we have to actually create a new link for the Zoom meetings, including the town halls. So after Wednesday, look for that, because a new link will be created for this meeting as well as for the town halls, and we will publish it after Wednesday. Okay, and it'll be on the website just like it is right now. So after Wednesday, you'll see something. It'll look the same, but it is going to be a different link. And if you have invited folk to be part of these conversations, first feel free to continue inviting people. This is a public meeting, so anyone that has a stake on this can participate. Feel free to invite. You don't need permission from anyone. Just share the link. And the other thing is that the next town hall is the 12th, 5:30 to 7. That is the opportunity for us on our side, the government agencies, the work group, to hear directly from people who are providing services or who are living with HIV and receive Medicaid and Medicare. So please know that those town halls are for us to listen. That's not for us to do anything else but listen to the community. And you can share the information. I will be sending out the links and the official notification this week, so look out for that. Other than that, thank you so much for giving us a couple of extra minutes of your life today, this morning, this Monday morning. And thank you so much. Also, I wanted to recognize that Representative Skylar Rood from the 16th District is with us. So it is good that Representative Macri was with us at the beginning. Rood is with us today, and the legislature is listening. So that is really good. We do have allies that are going to be working with us to make sure that whatever recommendations we bring forward to the legislature are attended. So thank you so much, everybody. And we look forward to seeing you again on the 12th for the town hall, for those of you who can participate, and on our next meeting, which is the 25th, I believe, October 25th. So thank you. Great afternoon. And if the team can stay here for a quick debrief.
Bye.
Tracy, you can stop the